Hey everyone, today we're building the ultimate study guide for IV therapy. Whether you're gearing up for the NCLEX or just want to feel more confident on the floor, we are going to cover absolutely everything you need to know. Let's jump right in.
So here's our game plan. We'll start with the absolute basics. Then we'll get into the risks versus the benefits, the why behind it all. Then we'll cover the safety rules you can never, ever break. After that, we'll dive deep into managing complications, which is where your clinical judgment really shines. And finally, we'll wrap it all up with some NCLX-style practice and a real-world scenario.
All right, Section 1, the fundamentals. Look, getting this foundation right is so important because everything else we're about to talk about builds right on top of these core ideas.
So, what is IV therapy really? At its heart, it's a direct pipeline into your patient's bloodstream. It's not just about giving fluids, it's a super powerful way to deliver medications, electrolytes, and even nutrition exactly when and where the body needs it the most.
And this is exactly why we use it. Think about it. A patient might need an IV for a fast-acting antibiotic to fight off a nasty infection, or maybe to rehydrate someone who's really sick, or to replace blood volume after an accident. Each one of these is a critical, life-saving reason.
Okay, let's move on. For a procedure that we do all the time, we have to be super clear on both the amazing things it can do and the serious risks that come with it. This is all about the clinical judgment that goes into it.
You know what's really interesting here is how the biggest advantage is directly tied to the biggest disadvantage. Rapid effects sounds great, right? Especially when you need a drug to work like now. But the flip side of that is you have almost no time to fix a mistake if you give the wrong dose. It's a total double-edged sword, and it means we have to be so careful.
Which brings us right to our next section, safe administration. Seriously, think of this as your rulebook. These aren't just suggestions. Following these guidelines is how you prevent major problems and keep your patients safe.
Every single one of these rules is a layer of protection. For instance, an infusion pump isn't just for convenience. For high-risk meds like heparin, it literally prevents a fatal overdose. And adding meds only to a new bag, that stops concentration errors. That rule about never mixing with blood or TPN, well, blood can get contaminated easily, and TPN is a complex mix that can react with other drugs. Trust me, every rule is there for a very good reason.
And now for the main event, managing complications. Because no matter how good you are, things can sometimes go wrong. The trick is spotting the signs early, knowing exactly what to do, and then figuring out how to stop it from happening again.
Okay, first up, infiltration. So picture this. The catheter is popped out of the vein, and now all that fluid is just pulling in the surrounding tissue. The classic signs you'll see are a puffy, swollen area that feels cool to the touch. Your first move, every single time, is to stop the infusion. That's it. Then you'll take out the IV and prop up the arm to help the body soak all that fluid back up.
All right, time for a quick quiz. You walk in, you see a patient's IV site is puffy and cool. What are your priorities? Take a second and think it through. Okay, the right answers are A, C, and E. You stop the infusion, apply a compress, and elevate the arm. But listen, the most important thing on this slide is why B is wrong. You never put a new IV distal to or below an infiltrated site. Why? Well, the fluid from the new IV would have to travel through that already swollen tissue, making it worse. You always go proximal, meaning above the old site, or just use the other arm.
Next up is extravasation. This is like infiltration's evil twin. It's the same idea, fluid leaking into the tissue, but this time it's a vesicant, which is a drug that can cause serious tissue damage, like blisters or even tissue death. The patient will tell you it's painful or burning, and you'll see redness. This is a big deal.
Okay, let's test that. You've stopped the infusion, you know it's an extravasation, and the hospital protocol says to give an antidote. What is your very next move? This is all about doing the right thing in the right order to prevent harm.
The answer is B, and this is so important. Before you yank that catheter out, you have a golden opportunity. You can actually attach a syringe and try to pull back or aspirate as much of that damaging drug as you can. Once you take the IV out, that chance is gone forever. It's a crucial step.
Now for a systemic problem, fluid overload. This happens when you've given the body way more fluid than the heart can handle. You'll see things like bulging neck veins, high blood pressure, and then that fluid starts backing up into the lungs, causing shortness of breath and crackles. Your first move is to stop the cause. Turn off or slow down the IV, and then sit the patient up so they can breathe easier.
Another really common one is phlebitis, which is just inflammation of the vein. Here's your big NCLEX tip. Write this down. Look for that red line up the arm. That's literally the inflammation traveling up the vein. The site will be warm and sore, and for treatment, notice the order. Cold compresses first to reduce the initial swelling and pain, then you switch to warm compresses later to improve blood flow and help it heal.
Okay, Section 5. Let's switch gears a bit and talk about how all of this stuff actually shows up on your exams and how you apply it to specific types of patients.
These tips right here are absolute gold. For older adults, their veins are super fragile. A regular tourniquet can be way too harsh and cause trauma, which is why a blood pressure cuff inflated just a little bit is a much better technique. Also, try to avoid the back of the hand. There's just not enough tissue there to stabilize the vein.
And here's a question that tests exactly that. You're about to start an IV on an older patient. Which one of these actions makes the most sense?
The answer is C, for all the reasons we just talked about. Using a BP cuff is just a smarter, gentler way to go. You don't want to shave because it can cause tiny cuts. You want to avoid the back of the hand, and raising the arm would actually make the veins drain, not fill up.
All right, let's put this all together in one final scenario. This is your chance to think through everything we've covered and decide what you would do.
Okay, here's the scene. Your patient is getting a drug you know can damage tissue. All of a sudden, they tell you it's burning. You look at the site and see it's red and swollen. Those alarm bells in your head should be going off like crazy. You've just spotted a serious problem.
So, my final question for you is this. Based on those classic signs of extravasation, what is your absolute first move? And what are the next two things you would do right after? Getting this sequence right is critical. It can literally be the difference between a little discomfort and permanent damage for your patient. Thanks for joining me for this explainer.